Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we have a distinguished panel joining to discuss important issues surrounding emergency medical kits on domestic flights in the United States. Here to discuss this important topic is Dr. Andrea Merrill, a surgical oncologist at Boston Medical Center, along with Dr. Amy Ho, an emergency medicine physician and Senior Vice President, Chief of Clinical Informatics for Integrative Emergency Services in Dallas, Texas. Also joining us is Leanne Mandelbaum, founder of No Nut Traveler and an airline correspondent for Allergic Living magazine. Welcome, everyone.
Thanks so much for having us, Rob.
My pleasure. Thank you for joining. Dr. Merrill, I'd like to start with you. A recent tweet you sent receiving nearly 500,000 retweets as you assisted a passenger with a medical emergency in flight going toward Europe. And what you found in the medical kit was really concerning. I'm going to let you discuss this in detail and what you did exactly to help support this patient.
So an hour or two into the flight, they overheaded that there was a medical emergency. They asked if there were any medical professionals on board. And so I ran up along with two other physicians, and they handed us what they told us was the emergency medical kit, which was a red bag. And I've never been in a medical emergency on an airline before, so I looked inside, wasn't sure what to expect. And we needed to take a blood pressure, and the blood pressure cuff came in 3 pieces. They're all wrapped in plastic, so you had to take them out of the plastic, you had to assemble the blood pressure cuff, which took some time, and then you had to take a manual blood pressure, and you had to use a stethoscope that they had, which was a disposable stethoscope. And I know most people out there probably use these disposable stethoscopes. You can barely hear anything in an office. Like, there's no chance that you can hear anything on an airplane. So, I mean, obviously you can take a palpable blood pressure, but to really have something useful, and if you need to take repeated measurements, you need to be able to take a good blood pressure, and it was just really impossible. They didn't have a pulse oximeter. We would have been good to have a glucometer in this situation. They didn't have one in the kit. I was curious, and so I just asked if they had an EpiPen, because one of the doctors said they didn't carry it, and they confirmed that they don't carry an actual Epi auto pen injector. And it was pretty bare bones what was in there. Luckily, the passenger was okay. We didn't need much more, but I was pretty surprised at what was in there and what was not in there. And had we really needed to do something emergently, I felt like we would have been unprepared.
Was the flight attendant able to help you in a way that you felt useful or supportive at the time that you were sort of fumbling through to get the right equipment that you needed to take care of this patient?
So they were standing nearby. Since tweeting, and a lot of other people like Dr. Ho and Leanne have replied to me, I've learned that they have other medications on the plane. Some of them could have been useful, but they didn't offer that, and I didn't know to ask for the other medication kit. I've also learned that they often can connect you with with medical professionals on the ground that they work with, and that wasn't made an option. Potentially it was because the passenger was doing well and they thought the situation was handled, but they didn't ask us, they didn't offer these services and see if we needed them.
Got it. Now, Amy, I want to bring you into this. So in this situation, and you're well familiar with this, there's a basic kit and a more advanced kit, and I'll let you delve into that and talk about, and to the point that Andrea is discussing.
Yeah, so I'm an ER doctor. I've responded to a couple medical emergencies, and part of my training in residency was actually in flight medicine, where we flew on a helicopter. So in there, you learn kind of all about preparedness, and we used to have to run our supplies like daily to make sure we had everything. So when I started looking at this topic a few years ago, actually, after just coming out of an emergency, just like Dr. Merrill's talking about, we realized that there's really kind of 4 categories of supplies that are required. There's an AED, an oxygen tank, a first aid kit, which is this really basic kit, and then there's something called an EMK, which is the emergency medical kit. That is a sealed kit. It's only supposed to be given to people who are like qualified for it, which is why you end up having to ask for it. The FAA has publicly available a list of what's in that kit. And actually a couple years ago, they went and asked for basically help from some of the medical associations to help revamp that kit. That being said, the current kit requires some basic airway equipment for adult and pediatrics. It requires basic IV equipment, a blood pressure monitor, a stethoscope, some cardiac drugs like 1 to 10,000 epi, atropine, lidocaine, nitro, aspirin. It requires bronchodilators and antihistamines. It requires pain medicines. And you're totally right, Dr. Merrill. It does not have like a pulse ox, it does not have a glucometer, because the airlines will sometimes crowdsource those from other passengers. That being said, this is the bare minimum of what you are required to have. So a lot of airlines can and do add more, usually at recommendation of their med control, which could be an academic center. It actually could be a corporate, usually occupation medicine group. And then you'll see that there's some variation because of that.
Right. And I think what you're saying, Amy, is very important, is that there's gradations. And, certainly if a medical personnel, EMT, nurse, physician is available and is comfortable, they can ask for that kit. And if they're aware of it, but it's this awareness that you just don't get that advanced kit up front, especially in an allergic type situation, emergency, someone who's having a cardiorespiratory issue, GI issue, and you name it. So Leanne, let me bring you into this. And the reason being that, and obviously with your experience as a journalist in this space, is that there's a sort of a disconnect here, that the kit itself has not been formally updated by the FAA in over 16 years. And there's a reason behind this. And I want you to get into this.
Well, the FAA last issued a circular on this in 2006 and formally updated the kit in 2004. So we've got to look at what's happened in the world since then. I mean, I can speak from my expertise as a food allergy advocate, and between 2007 and 2017, we had a huge increase. I think it's 377%. And that is actual emergency room claims that were filed. So these medications, for example, at a minimum, you should have an easy to use auto injector. Part of my job has been to collect testimonials, both from allergic families and from physicians. And there are a couple of issues with the vials. First of all, and most important, they don't necessarily have to be there, because the airlines have been granted an exemption for 5 medications, including among them the allergic concentration of epinephrine. So you may find, and several physicians have reported to me, more than several actually, that they've actually found either no epinephrine, only the cardiac concentration, and no auto injector. So then you're really stuck with no usable medication. Crowdsourcing is great, but what if you're an allergic family traveling, say, out of the country, and you have 2 auto injectors, and you give up your auto injector, then you get to, say, France, and you go out for a meal and you only have one with you. So there's that. There's the issue of vials cracking. So I have a physician who told Allergic Living that he cracked, there was turbulence and the vial cracked, and he actually split open his hand. So there's so many issues with that. And the other thing is there's a lack of crew awareness, just like you were saying, as far as the EMK, but even more so on training, so that they think the auto injector or the vials of epinephrine are magic, that they're going to work. But time is of the essence. You really need the auto injector if something is going to go south very quickly. And there's a well-known case on British Airways where a young girl died, and she had ingested something from the ground which had unlabeled sesame in it. And they asked the crew for the EMK. They got the EMK. It was a junior doctor. I'm not quite sure what that means. In the UK, he had just gotten his license, and the father had already administered 2 auto injectors, and she was dying, and they asked the crew to draw up 2 more vials of epi, and the crew said, we're not trained to do that. And so there actually was an auto injector. That was the saddest part. There was an auto injector there. British Airways voluntarily carries them, but because the crew didn't know. So it's not just the medical kit. The crew actually has to know what to give the physicians when they need it. There's such a lack of training and a disconnect. And we've also seen stories where physicians can't find what they need quickly because these kits are so disorganized. So we have so many issues surrounding these kits, and the FAA just needs to step in because you cannot leave it airline to airline, medical provider to medical provider. It needs to be a standard list so that passengers are safe up in the air. There's just no excuse.
So part of it is that they claim there are ongoing shortages, and that's what, the rationale is given for not having these medications. And in fact, I'm not sure if there's research, Amy or Andrea, is there research about these shortages, and how can we somehow address this? And we all know that there's medication shortages working in the hospital. That's a given. But when you fly, there should be a standard. It's not a flying hospital, but it's a place where hundreds of people are gathered for many hours, and we need to have standards in place, equipment in place, things that protect the public. And Amy, I'll let you start with you.
Yeah, so in 2019, there was actually a review with the Aerospace Medical Association, who brought in the American Pediatric Association, on what are the things that we need to add to this kit. And the EpiPen was absolutely on it for both adult and pediatrics. One of the major issues, though, with it isn't necessarily shortage, but number one, it's expiration. All these medications will expire within about a year or so. So it's recommended that the kit is reviewed, these are changed out, et cetera, but it doesn't always happen like Leanne's mentioning. And then number two is cost. Like, I think we all know EpiPens are extremely expensive. The 1 to 1,000 ampule of Epi is very cheap along with the syringes, but Leanne is totally right. There's no training by the flight attendants for it. They do go through a preliminary training where there's no physician related to that training. And so their role is really just to know that it's there and hopefully give it to someone on board, which is absolutely not ideal and can be dangerous. Here is actually an EpiPen trainer, but they all basically look like this. All you have to do if someone's going into anaphylactic shock is you pull the blue safety, and then you literally just hold it against someone's thigh for about 3 seconds, and that's what delivers the medication. Once you hear that click, you've delivered the medication. Fairly easy. How I think about this analogously is also similar to intranasal Narcan. It's very simple to use. In contrary, what the airlines actually have required via the FAA and the EMK kit is an ampule of epinephrine, which usually looks something like this. This one is not epinephrine, but it's usually a glass bottle. You have to snap off the ampule. What you have to do with that is you have to take a syringe. The FAA, actually, the smallest syringe they require is a 5 cc syringe, which is what I have here. But your draw up is actually only about half to 0.3 of a milligram or milliliter. It's 1 milligram per milliliter. And that's a tiny amount. I mean, even as I'm moving this on the camera, you can barely see it because it's only about 3 millimeters. You have to have a blunt fill needle to draw up the epinephrine out of the ampule, and then you switch it to an actual injection needle, which again, this all requires medical training, a lot of pieces that you have to find in the kit, and then finally you give it to the passenger. So obviously a lot of medical skill in an already stressful situation that people may or may not have the training for.
Plus, you're doing it in the aisle usually, a lot of people around you. There may be a turbulence, so you can't really steady your hand to draw it up, to open the ampule. It's hard enough to lean over someone to try and take a blood pressure cuff. I can imagine trying to draw that up would be a little bit challenging.
And so, going through this, it's apparent to me that there has to be stricter regulations behind not just domestically, but internationally, and getting everyone on the same page is exceedingly difficult. There's economic issues, supply line chains, and trying to arrive at this. So the question is, there's no database of in-flight medical events that exists actually in the US or internationally, where you could actually enter, incidents of what happened, outcomes to help with research. In fact, Dr. Yealy, in his publications in 2018 and 2013 in the New England Journal, actually talk about the rarity of such events, of in-flight medical events. In fact, allergic reactions are so low in this data from 08 to 12, it was 1.3% were allergic reactions. Most of it was syncope, pre-syncope, GI, cardiac issues and things of that nature. And so, knowing that it's rare to have anaphylaxis, and that's what they're quoting, this data is not up to date, and we need to update the database to make sure that we have an accurate picture of how often anaphylaxis or severe allergic reactions happens. And Leanne, I'll let you comment on this.
Well, let's start circling back to the FAA. The plane has to make an emergency landing or diversion for an actual report. I actually had an ER nurse who actually specialized just like what you did, Amy, in the helicopters, and she did not feel comfortable in a moment. It was a 10-year-old's first reaction to a cashew in the air, and she did not feel comfortable calculating the dose from the syringe into pediatric. So she did crowdsource, she did get an EpiPen, and this is someone completely experienced. I also reported Dr. Shaw quite recently had an emergency up in the air, and he and another physician came up to help, and the other physician was a urologist, just didn't know how to titrate the different concentrations. So Dr. Shaw actually told me he took time from treating the patient to show this person how to do it, because he said if the wrong concentration was used, it would be a problem. So we aren't getting these reports. They're not required. Nobody's collecting them. So if you think about, if the plane doesn't make an emergency landing and somebody else's auto injector is used, or I know people who've used their own auto injector, they don't want to bother the staff, because often you are taunted if you have an allergic reaction. I collect lots of testimonials where you're mocked, taunted, just harassed by flight crews. So you give yourself your auto injector in the bathroom. I know several people who have done that, unfortunately, and those don't go into reports either. So there's absolutely no way we're keeping track of these events. And in fact, I was part of a coalition to put auto injectors on planes. It was a bill that didn't pass. And we've discussed this, Robert. I think part of the reason it didn't pass is it included a provision for a GAO report on these reactions. And I don't think that they want these reactions tracked. And the FDA, they have the ability to change this now. In 1984, Ralph Nader's group sued them because they wanted to update the EMKs. And the court came back and said, no, you're wrong. You actually have purview. They said that the FAA does have purview and they can update the kit. And yet we sit here after these recommendations have come in, as Amy was talking about, to include the auto injectors, and we sit here and nothing happens. It's quite confounding to me.
So that was actually the 2018 review, or it was really December 2018's review happened in 2019, that there was actually a piece of legislation that said like, hey, we need to review this. And hence they outsourced it to, like I said, the Aerospace Medical Association. Right. That being said, like you are totally right, Leanne, like the reporting is not standardized, but there is some reporting, mostly just because there's med control. So like I mentioned, med control is often outsourced to private companies. It's often with academic emergency centers where they'll take a call, just like you take an EMS telemetry call. I did this in residency as well. And that's where they will see that there's events happening in flight. And the New England Journal of Medicine article that Dr. Glatter is talking about was a review of a med control for an academic center. So there's some data out there, but you guys are both right, hitting the nail on the head that there is no standardized way for all of this. But that being said, flight attendants will absolutely take people's information. They'll ask for your medical license a lot of times because they want to be able to leave a report on what happened. And some med controls will actually reach out to physicians on board that assisted to ask, hey, what can we do that's better?
They did take all my information down, and a nurse from the airline did call me a few days later to follow up on the incident.
But that was because the kit was cracked. So there are also instances where the person goes into anaphylaxis. I have several testimonials, and they're stabilized, but they're met with an ambulance on the ground, and they haven't cracked open the kit, and they get the injection in the ambulance. That is not considered an in-flight incident. So we've got incidents like that. So there's so many variables. It's very hard to get a data sense of what's going on. But obviously, I mean, just in the United States alone, we've got 3 kids in every classroom. We've got 48% of people who develop allergies as adults, as adult onset. Airlines are still serving the most potential trigger foods for these adults, which are tree nuts and shrimp, right? So they're still serving it. So they've got to come into the 21st century and have the right tools on board so that we have a positive ending here. You know, the doctors that are called up, we've got to give them the right tools. It's not that they're not available. And the American Heart Association lobbied really hard for defibrillators to be put on planes. And we need all the medical societies to come to agreement on these other medications. For example, automatic, auto injectors to be put on planes. If you're going to come up and answer to an emergency, you should have basic medical kits updated to reflect what's going on in society today. It just makes sense.
One thing I just wanted to hit on is that there are many physicians, nurses that are, specialized, and they may not feel comfortable handling all types of emergencies in air. And let's just be honest, if you're a dermatologist, a psychiatrist, someone who hasn't had really a resuscitative patient care, it can be daunting. You want to help, you want to be there, but if you're not trained and not really proficient because you haven't re-educated yourself on some of this, being called in the midst of hundreds of people to act can be daunting. And I think that's important to understand that, there's a need to step forward, but also you have to be proficient at what you're doing.
That is a really good point. Like, I have never had to draw up epi to give to someone having an allergic reaction. It's just not something I've ever encountered. I'm a surgical oncologist. I was to treat breast cancer, thyroid cancer. And if there was ever a situation, I was probably in an emergency room or somewhere else where we work in teams in medicine. So there are a lot of other people helping and doing things, and you don't have that on the plane. So you really need everything to be streamlined, more automatic, easier to use when you're in a stressful situation. You're also not expecting an emergency, so you're not really in that frame of mind that you're about to treat someone. You're on your way to vacation, enjoying yourself, and then all of a sudden there's medical emergency, and so it's a different frame of mind than what we're doing every day for work.
Absolutely. And Amy, would you want to add anything further to?
Yeah, I want to reiterate, Dr. Merrill, because I think coming from the medical world, it's important to remember, like, you have a team. That is what we learn in medicine. And when you're on an in-flight emergency, the airline attendants are your crew. Like I said, they do have some basic training, but they're obviously not a nurse or like a medical technician. But your crew is also other passengers who may volunteer. Like, if it's a syncope and you have a cardiologist right there, like, maybe they're going to be more helpful. I think also just remember that there is medical control. Every airline has to have med control on the ground, so you can defer. And of course, if you're a physician and you are on vacation and you've had like a couple drinks and everything, like, there's never anything that says that you have to respond to this. So always assess what your skills are, what your own capacity is in that moment. Help if you can, because it's probably the right thing to do. But if you're not in a place to do it, that there is a backup.
One thing is that the medical control actually has ultimate authority about what to do. The ground-based medical physician can actually tell the pilot either to divert or not, and that the person actually treating the patient doesn't have the final say. And I found that very interesting, that you're the person in charge of the resuscitation, but really the decision to land or divert is not made by you. It's the ground-based physician, which was concerning. And Dr. Merrill, you didn't have any interaction, you said, with ground-based medical control.
Right. Yeah, they didn't offer it. I guess, again, maybe because the passenger luckily was doing well and the situation seemed handled. But I didn't know until I tweeted and got all these responses that was even an option.
If a physician responds or if medical personnel respond on board, they won't always call med control. So just remember that, and you can absolutely ask for it.
There are some cases when there's no med control, because in that case that I told you where there was the death, it was a shorter flight, believe it or not, and they didn't have the radio length. They're not all connected. I also wanted to add that it's not just epinephrine that is exempt right now, and the FAA quietly renewed these exemptions for the 5 medications, and we just found this out that it was quietly renewed, Senator Duckworth's office, and it's atropine, dextrose, lidocaine, and both vials of epinephrine. What kind of situations could you guys envision with those other drug shortages not being there? I mean, I think this is not about allergies anymore. This is a public safety issue.
If we're giving those medicines, like, honestly, those sound like a diversion. Atropine, cardiac epi, like, those are all things where you're diverting and just trying to temporize.
And what if you're over the ocean?
Yeah, no, absolutely good point.
I wanted to talk to the group about having Narcan or naloxone in the kits. And, certainly withdrawal is an issue, but certainly overdoses as well. And I think that, based on the data and persons I've spoken with, is that withdrawal is more common than an overdose. But that said, I still think that's a basic medicine based on, our society now and the opioid crisis. And Amy, I'll let you start with your thoughts on this.
Yeah, I mentioned this previously that, I feel like the EpiPen versus an Epi-ampule is analogous to like the Narcan intranasal versus Narcan as as an ampule. So not required by the FAA. It is, however, on certain airlines. So when I started this pathway, I reached out to multiple airlines to ask what they voluntarily had added to their EMKs. American Airlines actually had Narcan intranasal. British Airways had Narcan IV, as well as oral buprenorphine, which I found was quite interesting. And then Delta had Narcan intranasally. So it is available, not standardized. And again, a lot of discussion on the delivery mechanism, just like with epinephrine.
With all these medications, again, I just want to stress, there needs to be standard requirements set by some sort of competent oversight governing body, such as the FAA, but also globally, because not only do you not know what medicines are, what kits, depending what airline, you don't know when they've been refreshed, because I reached out to several airlines for a story I was writing. I can't get a consistent answer as to when it gets refreshed, but then how are these testimonials from physicians making their way to me that they're over the Atlantic and opening up an unsealed kit with no epinephrine in it, or opening up a kit that says no epi in kit with a sticker, which was very recent. And I also want to add that the FDA has told me at the current time, and at the time of this testimonial that I took, that there were no epinephrine shortages in the vials. So I contacted FAA and I said, look, FDA is telling me that there's actually no shortage. And they're like, well, an airline must replenish when there's no shortage, but we don't know who's overseeing this. So are the airlines self-policing? That's what I'm at.
That's a good point. And some of the companies do have internal monitoring databases, and they do account for like when a medicine is used and when it's out of stock, when it's been either an ampule's been broken. And apparently this is an internal process, but it's not anything that's reported. And that's, again, the problem. And I think, that's where we stand. So Dr. Mellon, would you want to add anything else? Or?
No, I think that's a great summary that Leanne has. Like, these do need to be standardized. The FAA rules do only apply to certain flights. It'll apply to most of our, standard commercial flights, but she's totally right that there's exemptions. And so I know some ER doctors that actually keep a little bit of a personal medical kit on them to help respond to these.
Also, we shouldn't have to think to bring a medical kit with us when we're traveling because it's not available. When I'm on vacation, I want to be on vacation. Obviously, I want to help out if someone is sick or needs attention. But I would hope that in the air, when you're far away from an ambulance or other medical equipment, that they would have something available to help stabilize someone until you can get to a safe place.
According to MedAir, the what Amy was saying, the FAK, the first aid kit, and the EMK are both no-go items. So if you don't have them, you're supposed to not be able to fly, which is why they have these exemptions. So in case you don't have these medicines, the plane can still take off. The issue is how long can they do this for without replenishing? And we just don't know that. There's no oversight.
Right. Well, I want to wrap up here and thank everyone for really a very informative discussion about this important topic. I think hopefully we can affect some change. Again, thank you all very much for joining me.